Coast Australia. I have no vested interest in what we're discussing. The first quadrant here looks at patients who may be at risk of a dropped cataract, a vitreous loss during surgery, or those patients who are actively dislocating their cataract during surgery. The other three quadrants look at patients who have been referred to a retinal surgeon for intraocular rehabilitation. The vitreozonular apparatus is probably under increasing threat these days. We've got patients with PXF who've had intraocular lenses in for 20 years or more, and perhaps repetitive intravitreal injections cause some lytic effect upon the zonules. But nevertheless, if a patient undergoes or suffers vitreous loss during cataract surgery, if it's not cleared up adequately, traction and inflammation will cause visual loss, and even with adequate clearing up of the vitreous, we're left with the dilemma of how best to deal with the structural instability and how to place an intraocular lens. So for the cataract surgeon, and retinal surgeons do cataract surgery too, so for any surgeon doing cataract surgery, we look for any preoperative ocular features such as those listed there that might lead to increased risk. During surgery, things can happen. We try to prevent such things as epithelial edema, fluid pooling, and we try to deal with the claustrophobic patient, etc. So if we've identified an at-risk eye, we may want to stop pilocarpine if they're on it and start Diamox instead. We might want intracameral phenylephrine at the ready if they're on Flomax. We may want to use a peribulbar or local anaesthetic rather than topical in a difficult case. We may have pupil hooks, Malugan rings, Vision Blue, PMMA zonular support rings at the ready, and it'd be nice to be operating in a stable environment with a stress-free team. But despite that, these T-shirts can describe what can happen during surgery, and even this can happen when printing a T-shirt with this dyslexic T-shirt here. Now, if you recognise that vitreous is lost, you first need to, in this situation, recognise that vitreous may be about to be lost or is being lost. So you may see a deep AC, poor aspiration, the pupil may alter, the nucleus may rock, and the surgeon may get a slight sinking feeling. Having recognised that the vitreous has prolapsed, you want to stabilise the situation. You want to stop aspirating, stop the phaco, and put a dispersive viscoelastic in, which is less easily burped out of the eye. You then want to turn your attention to removing nucleus and cortical material from the anterior chamber, and the technique will depend on the severity of the rupture. You want to use low flow vacuum, avoid vitreous traction. As I said, put a viscodispersive in, fill the capsular bag, and levitate elevate the nucleus anteriorly. You may put a phaco glide technique using a Sheets glide. You may need to manually enlarge the wound to manually remove the nucleus. Depends on how severe the rupture is. You may have such a small capsular rupture that you can do a posterior capsular rhexis and still put the IOL in the bag. For the anterior segment surgeon, I guess for the posterior segment surgeon, I've used a posterior infusion. It allows me to do a full pars plana vitrectomy, perhaps a little bit more pressure on insertion of the 25 gauge or 23 gauge cannula. Anterior infusion, coaxial would be what most anterior segment surgeons would use, and it has the advantage of gentle flow, but the disadvantage is that you can sit there for a long time continually bringing vitreous up into the anterior wound. You can consider a Lewicky, but keep in mind that if you have that on with full flow, you will have turbulent flow and push nuclear material into the posterior segment. But a Lewicky self-retaining anterior chamber infusion line is an excellent way of entering an eye that has choroidals, and you can use this to start your procedure as a retinal surgeon and then swap over to pars plana insertion of infusion. For the anterior segment surgeon, it's worth recognising the anterior versus posterior dividing line. Once nuclear and cataract material in the posterior segment, it requires a posterior approach, and you need to avoid the temptation to go fishing. That's actually in New Zealand. Phil, I'll put that in there for you. I think an early vitrectomy would be preferred. I certainly prefer it. If it's referred to me, I'll get on and get it done as soon as possible. I think they have a lower rate of CMO, but the patients are happier. They have less symptoms with respect to their floaters, faster visual recovery, and less time for build-up of anxiety regarding the complication that they just underwent. Okay, we'll talk now as a retinal surgeon being referred these cases with dislocated cataracts or IOLs. There's a whole lot of decisions we need to make. At the top, how do we access the eye? As I said, if they've got choroidals, the Lewicky infusion is a good way to get started. Next decision is how are we going to remove the cataract? We may need to remove other bits of paraphernalia that our anterior segment surgeon has inserted into the eye, such as IOLs and Morse rings that have dislocated posteriorly. Do we want to use a frag? Do we want to use 25, 23 gauge? Do we need heavy liquid to float cataract or lens material forwards? And once we've done that, we want to assess the capsular support and we want to restore emmetropia. So if there's adequate capsular support, we may look at dialing existing PCOL, and if it's only slightly subluxed, or putting a new PCOL in the anterior capsule. Alternatively, if there's not adequate capsular support, then we look at those other options listed there. And in trauma cases, we may need to deal with iridodialysis, dilated pupil, or loss of iris. You have to decide what approach. In this case, it's a Marfan's patient with a dense nuclear sclerosis. I decided that it was too dislocated or too subluxed to allow tension rings, and too thick to use 23 gauge. So I've used fragmatome there. Of course, if you just got little bits of lens material at the back of the eye, you could use 25 or 23 gauge. I will point out that you should pay attention to the vitreous base, and especially look out for those patients that are cataract surgeons had a complication and they're just grumbling along over a few weeks or a few months with recurrent uveitis and cystoid. Do indent, and you may find lots of little nuclear chips and cortical pieces around the ciliary body, just behind the iris and around the vitreous base. And I'd also recommend trying to induce a posterior vitreous detachment at the time of surgery. If there's a dislocated intraocular lens, you may need to pick this up from the retina with or without